a consultant clinical oncologist, and the head of the unit, who are going to be sharing their expertise in setting up a patient navigation, both at the institutional level and also community level. And then thereafter, we'll have those two speakers presenting what we like to call a case presentation. And then thereafter, we're going to have a didactic discussant by Patty Gravett, who is the Deputy Director for the Center of Global Health, US National Cancer Institute. The bios have already been shared, so I will advise you to look at the great works that our speakers have done, particularly around patient navigation. And with that, I think we'll get right into it. So Pamela, if you are able to set up your slides, and then we'll take Pamela, who will talk about their experiences setting up at Eldoret in Kenya, and then Dr. Oko will talk about setting up the patient navigation unit here in Nigeria. A few housekeeping rules. Please, if you are not speaking, kindly mute yourself. We would like to see you. If your bandwidth, I will be going back and forth to see what's there when we go into the discussion section. Pamela?
Good evening and good morning, everyone, depending on where you are.
Pamela, we see your slides. Do you want to proceed?
Yes. Can you see the slides?
Yes, perfect.
Okay. So thank you very much.
Yes, Pamela, we can see your slides.
Yeah, thank you very much for that elaborate introduction. And you've said it well. I would like to take this opportunity just to greet everyone, depending on your timing and where you are. And as you have been told, I am Pamela. We work with the International Cancer Institute in Eldoret. Wow, I'm trying to scroll it and it's not moving. So International Cancer Institute is a not-for-profit organization dealing with provision of comprehensive cancer care in the sub-Saharan Africa. It enhances capacity building in oncology through education and training in various cancer and preceptorship courses. It is registered by the National Commission for Science and Technology and Innovation to conduct clinical trials on advanced therapeutic molecules for various cancers and sickle cell disease. It has partnered with the government and non-governmental and faith-based organizations that is timely and optimal. So that is the International Cancer Institute Research and Care Clinic. It is also registered by several local bodies like Kenya Medical Practitioners and Dentistry Commission. It is Council. It is also registered by Kenyan Clinical Officers, Council, and TVET, all the local bodies that are supposed to do registration for an institution to work. It is also affiliated with the European Society of Medical Oncology and UICC. Our facility is also accredited by the National Hospital Insurance Fund and AAR, which are the local health insurance, amongst others. We work in partnership, both locally and internationally. So locally, we work with Kenya is divided into counties. And as you can see that map, areas shaded in green are counties that we have already engaged with. The ones shaded in yellow are the potential engagement partners. And we also work with Rwanda, Tanzania, Uganda through Blueprint for Innovative Healthcare Access Program. So when we look into cancer burden, there is a global disparity in cancer care depending on the geography. Like the lower and middle income countries perform poorer than the higher income countries. We know that more than 80% are diagnosed at late stage or with late stage cancer. We have fragile health systems. We lack quality and affordable medications. Also, sociocultural barriers are also an hindrance and misconceptions. We also have financial barriers like unemployment, high cost of treatment, and fewer cancer care facilities are available. Majority of cancer specialists are also based in major cities and major towns, whereby the people who are, most of the people who are affected lack access to specialized care. Cancer care is a specialized care. So why talking about patient navigation? Activities, it increases, when patients are well navigated, the increase in screening participation. There is also timely cancer diagnosis, linkage to treatment and follow-up. Clinic appointments are booking and in good time. Navigation through complex health systems, like what we are going to see. Language barrier is also a hindrance, so we need patient navigation to navigate through that. We also need to navigate them through patient education and also to help improve on treatment adherence rates. So if you can look at this map, this is the complex movement of patients through the facility. And I'm using an example of a baseline activity that we did, led by one of the nurses. And out of this, we realized that navigation is key. Because when you look at the green line, a patient arrives in blue. Green is a ghost. In the record session, the patient will be accepted for start of activities when maybe they either have cash or maybe they either insurance cases. So if they have a health insurance, they will have to go to the health insurance office to verify. They would go to the health insurance office to verify if they are actually having a valid insurance. Then once that one is approved, they would go to a billing office whereby an invoice would be generated, then invoice back to the registration, and then just the way the lines are going back and forth. Then a client who comes and does not have money and does not have any registration and any insurance would get to the records. And remember that one, I'm talking about 2018, would get to the records. From the records department is referred to go to the social work department. So you see the arrow coming from the records to the social work department. Then at the social work department, the patient would be referred to the, after getting maybe being assessed, then they get a waiver for consultation or for opening the file. They go back to the records, open the file, go to the triage. The triage nurse sends them to the consultation. After consultations, maybe they're sent to the lab. They go to the lab. The lab puts their bill. The patient leaves the billing room, goes back to the social work for another waiver, and that kind of, you see, it's kind of a problem. Movements from one place to the other, one place to the other. This would take a patient like maybe 3 days before even his needs are attended to. So this one, we are looking at the institutional level. But the question was, what is happening back there in the community before the patient got into the institution? So it was a real challenge. It could take like maybe 3 days to 1 week before the patient even gets the services, depending on what you have. But even a cash patient, you come with your cash, you don't know where to start, you move around. That's the person with green. You move around, going here and there, keep asking people, sometimes you are directed to the wrong direction, and then we realize something is absolutely wrong, and we as a team, we have to come up with something which will make a difference to these clients. And thus the need for patience for navigation. So in establishing patient navigation, we sent a team of five to Kenyatta National Hospital, which is a national hospital within Kenya. And that is where we had navigation was taking place. So these people, we sent them for benchmarking and training. And also the senior nurses who are working within our institution were offering mentorship to county staff and navigators so that they would be able to send the patient to the right direction or to give them the right guidance as they come for treatment. Navigation, we had two categories. We had professionals, like nurses and doctors, and also lay navigators, which included the cancer warriors and non-medics who came in to be able to help in patient navigation. And then also there is empowerment. How do we recruit? The recruitment of cancer warriors, and also training the cancer warriors, and also having face-to-face mentorship with cancer warriors, help others navigate through, because we prefer them because they had gone through this system and had seen how hard it is and improved the services, though we have not reached where we want. So I want to just share the model of ICI navigation. We are doing it in three categories. We have health system navigation, patient-related issues, and disease-specific issues. In health system, we navigate right from the community. We look into how these people can be screened, and cancer prevention is at different levels. So in screening, how do they get access to care? Because when we do mass screenings or maybe facility-based screening, you find people with lesions, or we find people with issues. So how do they get care? And once they are screened, how are they referred for pathologies? And if that is the case, we have to refer them to the right place. Or when we do screening at these facilities, we do the biopsies and then get the biopsies to the places where the biopsy will be processed. Then at this level, we have to find out if somebody has health insurance or not. So we navigate them on how to get health insurance. If they can get some people to sponsor them, or some philanthropists, or maybe they go and look for their relatives to have health insurance, because that is the one sure way of helping them to get treatment. Then how will the care be delivered? When we deliver the results, do we take it to that facility, or where do we navigate them to get their results, so that we link them to the care providers at the county level or at the referral hospital? So in all these levels in healthcare system, we also engage the community health volunteers, mobilize people from the village level. They will also help us whenever the results are there, because some of them do not even have the phones. So we have to contact the community health volunteers within their unit to reach them with the information. We also have integration of the survivors as part of the navigation system. Then in patient-related issues, there are issues like transportation. How do they move from one place to the other, and who assists them to move there? And where can they get the information of how to move from one place to the other? Then there are myths and misconceptions, self-management. How can they manage themselves as they look into how to get treatment? If there is any things like language barriers, how do we go through this, and whom do we link them to? How they can get maybe information communicated to them. Also adherence, appointment compliance, education and educational materials, and also support groups and skills development. Through the support group, when we have the support groups, How do we link them up and they know where they can go for support group meeting to encourage one another? Also, we have disease-specific issues where we need counseling, social support, or like in social support, how center. Maybe if they are coming and maybe staging is to be done and they have to stay in major towns, like I had mentioned before, that cancer services available in major towns, and most of these people come from the rural. How will they get themselves accommodated there? We navigate them through, and ICI has a wellness center where we keep them there as we do staging or as we process their treatment. Also, we encourage them.
Pamela, if you could round up. Hello, Pamela, if you could round up.
Yeah, I'm almost. Business enterprises, small scale business, and we also got some funding from Children's Place, which we are helping them to empower them back into the community. Also in food and nutrition during treatment. We work together with African Cancer Foundation, and we have helped them to initiate corn gardening. And also this is a support group meeting where they train on skills development. Then in closing the gap, ICI really had a time, especially during COVID-19. So we had to work with the counties through virtual tumor board, teleconsult. We also developed revolving fund pharmacies, virtual preceptorship, and on-job training so that these people could be navigated at level. And when we look at how we can close the gap, sitting on navigation through at the following levels: is community health volunteer, facilitate linkage, patient referral from community to health facility. Patient survivors, how do we empower them to offer psychosocial support, navigation? Then to nurses, for nursing visit, and clinical navigators within the health system. And also we are working on how people are going to participate in the virtual preceptorship courses so that they can, and those are my references. Thank you.
Thank you so much, Pamela. So that Dr. Okwa can quickly put up his slides. Thank you for walking through the essence of patient and for with us the model that is being used in Kenya. Dr. Okwa, if you can. I don't see him.
I don't see him. Are you with us?
Okay. Okay, so.
Oh, yeah, he's just
okay, yes, he's here now. Okay, Dr. Okwa, I think you are up next. If you can quickly start sharing your.
Okay, thank you. Please, can you help me share from your side?
Okay, Charles, is that something you are able to do? So while we're getting the IT set up, if you do have questions, please drop them on the chat. We'll be able to come up during the discussion section. Pamela had the essence of patient navigation, trying to close the gap in the system. So, right, so Dr. Pamela has laid the groundwork and told us what patient navigation essentially is. In the interest of time, if you can just share with us how we were able to set up the patient navigation system in UNTH, because we are behind with time.
Okay. Thank you very much for this wonderful opportunity. This is a patient navigation program because of Nigerian experience from grounds up at the facility and local level. By way of introduction, patient navigation is a community-based service delivery intervention designed to promote access to timely diagnosis and treatment of cancer, as well as reduce the burden of care. It is an assistance offered to health care consumers, patients, survivors, caregivers to help them attain the desired health care. Next. Patient navigation program. Sorry, couldn't come up.
Do you want him to advance the slide one more?
Yes. Yes.
Charles, if you could. Yes. It's where you talk.
I couldn't see it. Okay, let me continue. Like I said, patient navigation is a care, disease care disparity, hence prevalence, mortality, burden of disease in disease health exists. Increase both patients and providers satisfaction. Is the type of system error, staff disposition to duty, patient with their relatives and caregivers. In my center, University of Nigerian Teaching Hospital, because was created of passion to alleviate the suffering. It has been a wonderful experience working as a navigator. You cannot work as a navigator and it's one. Many navigators, but are not recognized, simply do not have the structural formation or the framework. I work in an environment where cancer patients seek medical care at advanced stages. Expect you as the doctor to perform magic disease, but not willing to participate in the game of the magic. And most, not of them having little or no knowledge about the disease. The magic is to cure the disease. The game is to screen earlier. They want you to do magic to cure the disease. They will not screen so that the disease can be discovered curable. So that's the environment we find ourselves. Now we have a lot of challenges by these our patients. And they include, but not limited, health information. They lack health information, communication, language barriers, transportation. So where you have facility like radiotherapy is a challenge. Getting accommodation, you go to a center where you cannot, there will be no accommodation for patients except those in a bad state that can be admitted. So you need to go and look for accommodation elsewhere. There's a lot of beliefs, wrong beliefs and myths. They already have difficulty in knowing what is available. They have poor knowledge of the treatment plan, have little or no possible idea of what is disease recurrence. Many of them believe if you just complete the treatment, it is all over. I don't know that in 2 years' time, 3 years, that depending on the stage, and other factors, the disease might recur. Not well informed. There's a wide gap between patients and care providers, and hence enormous unmet needs of cancer patients. Unavailability to complete cancer care as a result of not having equipment complete in one institution impose patients on a great threat to treatment completion. Also, most times patients may be transferred to another institutions. They won't want to go. They will tell you their condition. At this point, it has come to the end of their life. If you cannot save them at this particular institution, they cannot go anywhere. Especially the very poor ones or the elderly one will not accept to go anywhere. Rather, they will stay and face the deaths. Also, many of them know and believe one doctor can treat them. They don't know you need to maybe see a surgeon, you see a medical oncologist, see a radiation oncologist. So it becomes challenging. They're well informed about all this. They don't know that treatment is step by step. They expect this, they meet a doctor, the treatment will be completed with the doctor. Now, in addition to that, financial challenges, other factors, psychosocial issues, prolonged waiting time between the initial presentation and commencement of definitive treatment, incessant breakdown of radiotherapy machine, and many side effects of radiotherapy orders. Now, unresolved questions include where and when patient navigation should be deployed, when to commence and when to end navigation program, who to finance navigation program. Is it the hospital management? Is it the patient? Or is it the people showing compassion? Now, following these observations, we made a request to the hospital management, a patient navigation program in the University of Nigeria, and the request was granted, though with no financial backing, but it helped us because it went a long way to help us in the logistics and the planning. I organized the frontline staff to set up the patient navigation program in our facility, and among them, doctors, nurses, social workers, psychologists, administrators, hospital administrators, cancer survivors, and volunteers. Now, to meet up with the demand of the patients, staff of patient navigations were drawn from different fields of medicine and hence multidisciplinary in nature. Rapport and good collaboration with the management as well as the positive impact created by navigation in the hospital management went on to expand the patient navigation in oncology to hospital-wide and ensure that patients, navigators are in all the major clinics covering all the chronic illnesses. Currently, we have up to 42 staffs in oncology, in navigation units, and we cover different clinics in the teaching hospital. Now, achievements so far, we developed an institutional-based patient navigation protocol. We established advocacy network, engage patients on cancer support group, create database for patients, and help us for follow-up. And we network with other NGOs. Now, growing a responsive and integrated patient navigation system, the following are to be considered. Set a goal with available resources, identify the workforce. You need to identify the people that you can work, just as in our setting, we got the frontline staff, people of like minds, people that have the same passion. Define the scope of practice and get the hospital involved and collaborate with other NGOs around, if possible. You need to get the hospital involved because you cannot handle it alone. If you want to work alone, they will not understand their plan, their aims and objective, and it cannot work. So you need to let the hospital know. So we have to set up a proposal to the hospital on the need for patient navigation to the head of the chief medical director, and we liaise with the management to set it up. Now we look at the literature, what has been done before. Yes.
Dr. Oppo.
Yes.
Please, can you round up in 2 minutes? Thank you.
Okay. So we looked at the literature, what has been done. We established collaboration with other people. We developed a protocol in our center. Then to sustain a responsive integrated patient navigation, we train personnel to understand and align with the goal, work on patients to understand that the program is for them, and train the patient navigators on the expected function and scope, work on possible collaborators, identify the gaps in our system, the language barrier, which presents the knowledge so that people they can take care of that. Also, source the volunteers in our, we work with them, we empower them and we tell them to engage on survivorship plan, and we make resources where these are the support group in our institution, and we have we are asked me tag, so be identified, and we feel glad doing the job. Thank you very much.
Thank you so much, Charles. If you stop sharing now, Patty. At this point, we'd like to welcome our didactic presenter who will try to shed more light on the various models we've heard and help in implementation strategies that would improve impact. Patty, thank you.
Great, Amika. Thank you so much. And thank you to the two speakers. I think you guys gave a great introduction to the challenges of service delivery and patient navigation in cancer care. And I'm going to, by sharing my screen, I want to frame this in a couple of ways, because once I spoke with everyone previously, it really came to me that this is an issue of perspectives. And I want to start this discussion by asking you all, if you can see my screen, so let me know in the chat, what animal do you see? And Amika and Mishka, I'm going to ask you guys to kind of to what responses are.
Okay, so most people, dog, bird and bunny, bird, rabbit, a bird and a bunny. Do we have more coming in? A duck, bunny, rabbit. I see the bunny now, rabbit and bird, rabbit.
Right, exactly. And so what's really interesting about this is it helps us to realize, you know, so if you guys can't see both, it took me a long time to see the bunny. I looked at it as this was a duck's bill and eyes. And so I'm looking at it from a left facing, but you can also look at this as a little cute nose, eyes, and bunny ears. So this is kind of a bunny who's a little bit worried and apprehensive about what's going on in their world. I wanted to think about patient and a health system to realize that how our system works and what is needed, you know, there's a universal truth to that. But it's really important to recognize that we have to think about patient navigation and how we can make the patient experience better, and also kind of understand, you know, how we can make change through patient navigation, and whether there are multiple ways to do that. And that's going to depend on us being sure. And I think that both of the speakers today showed exactly how you do this. You need to think that from the patient and community's perspective, they're looking at the system and they're seeing one thing, and their beliefs and how they're seeing the system is going to be informed by a lot of cultural factors, a lot sometimes of myths and things that are propagated in the community. We also have a system, and I'm going to just move this around to say systems are often kind of the patient and healthcare provision within the clinic. But in addition, you know, it's our governmental institutions which dictate what we do and provide or don't provide, you know, the necessary services. And then it's the financial system that's going to pay for all of this, which we've talked about. And of course, each of these three are going to look at kind of what needs to be done in order to provide the best cancer care for the community. And they're going to look at that from a very different perspective, right? And so I'm just going to go up and kind of frame our discussion, and hopefully can facilitate this with some of the comments that you guys are going to have. I'm going to give an example of what I work with, which is very early cancer care, and that's patient navigation through cervical screening. And at the top of this, if you guys can see this okay, I'm going to expand it a bit, is that this is kind of the algorithms that we develop in our national cancer control plans. You know, that we're going to screen, and people are going to go through a series of steps until they can get, you know, the appropriate treatment. And you can see that looks relatively simple, right? But here I'm showing you, this is what it actually looks like, both to the health system in terms of how the health system has to function, and to the patient, which is they're going to have a lot of things going on in the community, a lot of things that are happening in the primary health centers, things that might be happening in laboratories or imaging laboratories, things that are happening at the hospital or cancer centers. And all of that needs to link together somehow through information systems. And I really liked how it was framed of, we need to think about patient navigation from this perspective, right? What is it? We need to map out the processes, and we've seen some of the complex processes where people get sent in different places depending on what kind of insurance they have or how they're paying for services and things like that. And so I wanted to kind of start thinking about, how can we think about different health systems and patient perspectives and answering some of these unanswered questions that were navigated. And so from that perspective, do we have any questions that we can start mapping on to some of the answers that lead to what kind of shared experiences you've had with the speakers already? What kind of things do you think are still needed? How can we facilitate this better? And I'll ask it from both what we can do to intervene at the patient level, but also what can we do to intervene at the health systems level, maybe just to improve patient navigation through changing our health system structures so that it makes it easier. So do we have any kind of suggestions or comments about how we could do this? And I can add them to this graphic. So one of the things I think we can talk about is, where should patient navigation begin? And that probably is going to depend on what kind of things. I mean, I think from my perspective, that's going to depend on, navigation at what point of entry, right? Because I've given an example of a point of entry from the time of invitation to screening or awareness of screening. From a lot of the perspectives that I'm hearing now is, a perspective of the cancer care. So how do we wait, so should patient navigation begin in the point of the community of raising awareness of symptoms and knowledge about where to go initially to get those symptoms evaluated? Should it begin only when the person presents? What are the thoughts here? And what's the experience that everybody has in terms of where patient navigation may be helpful? Who does it in terms of the entry points?
Okay, maybe if I can contribute to that from
Sure.
the local experience.
Mm-hmm.
The patient navigation.
Well, I think while everybody's, I'd say that, okay. Oh, go ahead, Pamela.
I'm saying like as for now, the patient navigation starts at when the patient presents with the symptoms. But in the actual sense, the patient navigation should start from creating awareness in the community through maybe the community health workers or health volunteers, passing the information even about screening or about the abnormalities that can be identified to make somebody think that something is not right, or maybe just carrying people through healthy livings, health information, education materials, and things like that, right from the community. But as it is now, especially from our Kenyan experience, it starts when somebody presents at the hospital, but it should start right from the village.
That sounds great. And what kind of, in your experience or the experience of any of the participants, who actually, are people that you think are good to establish that first point of patient navigation in the community?
I think just to re-echo what Pamela said, I think it should actually begin in the community, because for us here in Nigeria, we still have a lot of stigma, myths and misconceptions that are associated with cancer. And so getting people to talk about it, having open conversations right from the community when everything seems to be normal, would definitely be a strong way to improve uptake of screening facilities. So in terms of who should do it, we don't have patient advocates, but I think if we did, that would be the person really to do so, because then they talk about it from their own personal lived experience, and that storytelling might actually be more powerful. But where we're still trying to develop and build patient advocates, I think community health workers, people who have actually been trained, like we saw in Pamela's presentation, where they have community engagements. So perhaps having those who have already undergone the training might work, because they live in the community, the people know them, they speak the same language, they are able to communicate effectively, you know, using the terms and terminologies that are really common to that society.
Right, and I think that it's important probably, and you know, to engage those community health workers and the community advocates with the doctors, so that we can, you know, do you think it's important to get a common language that we talk about things, so that when they're at either place in the community or when they go into the health facilities, that there's a common kind of language that's well understood? So is there a lot of experience in your worlds of you know, how you can develop that kind of common language?
I see Paulette has put something in the chat. Do you want to say so? Are you addressing the Paulette?
Sorry about that. I got a call, so I got cut off. But I just wanted to say that I think the first step, it would really to even identify how to engage the community health workers, because as Dr. Cox said, that common language already exists. Most times the community worker speaks the language, is from the community, knows the nuances, can potentially, with the right training, best communicate it to the community members appropriately, you know, in the language that they would understand, not necessarily in terms of whether they speak the same language, but really whether they communicate in the same way, right? So I think that that's where we would even need to start to just equip those folks as change agents.
Yeah, so it's kind of, it's not just kind of the, maybe a local language or dialect in terms of, you know, maybe English versus French, but it's also kind of how do we refer to things that are important and when we're communicating about our health, right? And I wonder, so we can train, you know, so the community, we can train the community health workers so that they can convey the important information from the health system to the communities. I'm wondering if we also, do we have training in the reverse in your experience, so that the words that the community are going to respond to and use are also given to the healthcare providers, so that they understand how, you know, kind of the perspective of the patient? Is that something that happens regularly in your experiences? So that,
No, not from our end, no.
So do you think that could be another way that we could do that, so that when the patient actually gets into the health system, where the patient navigators may not actually be with them every time, if we could do, you know, would it be helpful in your mind to kind of train the physicians and the nurses and midwives on how some of the key principles in terms of how they're going to describe symptoms or body parts, that there could be some provider training so that they can, when the patient's actually with them, they can kind of speak and it's, you know, kind of communicate more during that context?
Yeah, I think that would definitely help. I don't know what our speakers think as well, because just recently we were in about how the messages that we there translated and yielded the kind of impacts that we want, and that one potential suggestion was that perhaps we are not saying what they understand. So I think that's a definite yes to your one. But I don't know if Pamela or Okpo would want to talk about their experiences at their own place too.
Well, I want to say something. In addition to community health workers, like in our system, where there's a lot of belief, religious belief, is important that these religious leaders are also trained alongside with the workers, because most of the time you may not have enough community health workers to attend to the normal compared to the religious leaders listening to. So if actually leaders, the need for them to screen, need for these are the common presentations people can call, they start manifesting with overt kinds, then will go a long way, because one reason is that religious leaders too are also among the major problems we also encounter in the treatment. They most of the times give them faith that, okay, this is just common something, you pray, everything will be over. And sometimes they will just pray and do not do the medical treatment. The thing is that you pray, then you also do the medical treatment on the two, and the religious leaders. It will go a long way.
Right. No, I think
maybe also to add on to what Akal said, looking faith-based leaders, we should also focus onto the traditional healers. That in the community, people believe a lot of times who treat them there. So sometimes they have symptoms which the CHVs don't navigate them to the hospital, but they first go traditional healers. So if we find a way of also engaging them in the process of patient navigation, we can be able to.
that's important. And I think one of the things that I found, at least implementation research and systems thinking kind of principles, is one of the ways that you can orchestrate this, because what we're seeing is, we need to kind of get what we call sometimes, sorry, I'm typing and thinking at the same time, what we call a shared understanding. Right. And so one of the things that might be interesting in terms of developing a patient navigation program is getting all of these different people, at the point of engagement, as you're talking about, which I'm hearing a consensus at the point of engagement, where it right now is presentation at the hospitals, it should probably be in the community. And that way that would be a really important way to get people in sooner and have a higher success rate of our interventions, particularly when we're talking about getting people in for symptomatic cancer. And so one of the things that I've noticed, at least, and I think would be interesting, in any setting, is whether or not we even start with the same understanding about, cancer processes. And so getting all of these different stakeholders together. So patient advocates, community health workers, providers, faith-based, getting them together to first make sure that they understand the cancer care continuum as it exists in their community. What's offered, what's available, what's it for? Give that shared opportunity to look at the myths. I'm sure you guys do. Sometimes what I've seen in my experience is that it's often done independently, and I'm going to just throw, we're considering, bringing people together and make sure that the different perceptions or perspectives, as we talked about at the very beginning, actually the same. And I think that could be really interesting. For the sake of time, we only have 10 more minutes, and I wanted to kind of go in, put in the comments here from Cancer Society that there are different kinds of navigators. And so I've put this in because I think what we do is to link what kind of navigators we need at what point in terms of looking at where and when patient navigation begin and end. It probably depends on what type of navigation we're looking at. But let's talk a little bit about in the African context, where did we typically end patient navigation? End patient navigation.
I think typically it would end within the hospital as well. So with all the conversations I think it should go beyond the hospital. Pamela, what's your experience in Kenya?
Okay, my experience is that patient navigation, like setup, it goes beyond the hospital. Because when you leave them hanging, not knowing how they have ended, we will not be able to close the care gap. We can only close the care gap if when we release them in the community, what are they doing? Are they able to support themselves? Are they able to have some preventive measures so that we don't have disease recurrence, whether it is hepatitis or cancer, whatever disease, because navigation is only for cancer. So it should go beyond the hospital, our community, until we come to how we can close the care gap.
That sounds great. And what kind of things have you done and put in place to, what can you give some examples of the kind of navigation that's being done in the community after a patient has completed treatment?
Thank you. After a patient has completed treatment, remember in my presentation, I showed the corn garden. Have to look into their food security. How do they take care of themselves? Maybe they spent everything during the treatment. They're going back to children falling off the pool. So our organization, when we got some little funding, an award that Professor won from the Children Foundation, he brought it back, and we used this money to help those people back. Meaning we assessed, and if someone was doing a business and used all the spending on this treatment, we gave them some little money to start them up. And we have been monitoring and following to see how it has worked out. Though COVID has interfered with them a bit, but they feel that they've picked up quite well. We are also engaging them in skills training, that if they know even how to knit something like those prostheses, locally made breast prostheses, that they can sell and earn some little living. So those are just a few examples of what we are trying to implement in the community.
Yeah, I think that's an important point. And, and I think what that's also pointing out when we think about kind of the, the system that's involved in cancer care, this is going well beyond, the health care and the cancer care. And this is going into, quality of life, employment, right, education. All of these things are going to be different parts of the system that we need to engage when we're thinking about a kind of complete cancer care continuum in order to have our patients thrive even after cancer therapy. And so you can see how the stakeholders start to, rapidly accumulate. And so engagement in them, again, in this shared understanding at the very beginning, right? And getting people to all have this perspective of, from a patient-centered approach, can we look at what this cancer care continuum is going to mean outside of the clinical setting and inside the clinical setting? Do you guys think that in any of your situations that there could be any kind of, and I see there was a raised hand, please stop talking and just
So Corey,
I'm pronouncing your name correctly. So
no, that's fine. I already did that for you. Professor Corey, go ahead.
Okay, thank you very much. These have been very exciting discussions and very informative. I just wanted to chip in that the UNTH navigation that Dr. Okwo presented is able to provide a kind of navigation club, patient club, where survivors come and meet up with those still undergoing treatment and interact, discuss their challenges, and able to more or less like iron and interface with also the caregiver, the healthcare providers. I know I've been in one or two of those kinds of meetings. For the NGO that I also belong to, what we do is to just encourage them to continue to communicate and help us to know exactly what their challenges are, outside of the hospital environment when they get home, follow them through with some of our volunteers and all that. So I feel that kind of support can also happen. And it also helps you to maintaining contact, also helps you to know exactly when you should give them advice on you need to, seek medical attention immediately from what you're telling me that is going on, and also assist them in any way you can to draw attention of philanthropists and all that to some of the needs they have, like paying of school fees for their children, being that, they have been really financially debilitated through out-of-pocket payments. Thank you.
That's perfect. I'm trying to capture what I'm hearing in these notes that we can send out to everyone who's participated. But I think that is like a really great example of kind of the interaction between the healthcare system and these survivor peer support networks. And if we do this correctly, right, we can have this shared continuous learning. So you can learn what's happening in the field. How do we need to modify our systems in order to be more responsive to patient needs, understand things, because their needs are going to evolve over time.
Thank you so much, Patty. I mean, I see we have just 2 minutes to the top of the hour, and I think it's been very interactive, very interesting. I think we can, for those that still have questions, we can continue via mail. But I think this has really opened it up a lot, lots to think about, even for countries that are, or institutions that are really trying to set their own patient navigation program. This has been very instrumental. Indeed, you have shown us that in terms of engaging the partners, we really need to cast our net very and see how we can intervene at different points in their care. So at this point, I'd like to turn it over to Charles. But before then, I'd really like to thank our excellent speakers, Dr. Okpo, Pamela, and of course, Patty, for really doing justice and practicalizing all the things that we have, the presenters had talked about. So Charles, I'll hand it over to you as we wrap up. Thank you so much. And to all our participants, thank you for a very engaging hour.
Thank you so much, Amaka. And indeed, thank you to our facilitators for today, our speakers for today, and also everyone for joining us today. It was a very lively discussion. And we are going to be sharing the recording and the slides as well on Basecamp. And we can also continue the discussions over there. And if you're on Basecamp, touch with Mishka, and she can add you there. Our session will be held on that March, that is 2 weeks from now, same time. And we are going to be focusing on digital stroke health, and specifically on how to harness digital platforms in cancer patient management. So please plan to join us, and we are going to be sharing the agenda soon and the meeting link. So look out for that as well. Otherwise, thank you very much. I don't know whether Mishka, you have something to add.
Nothing for me. Thank you, everybody.
Thank you. Thank you, everybody. Thank you, Okpo. Thank you, Pamela. Thank you so much, Patty.
Thank
very
you so
engaging
much.
Session. Right. Bye,
Wonderful
everybody.
organization, Amaka. Bye-bye, everyone. So nice to see you.
Thank you very much.
Thank you. Bye.
Thank you very much.